my colleague and a very good friend. He's from He's from KMC Manipal. Right now, he's working as associate professor at KMC Manipal. He has completed his DM infectious diseases from AIMS New Delhi, and he has also started Center of Infection Immunology and Intensive Care. And he also, is a very nice speaker. I like the way he approaches things. I have always, I always like giving him very difficult topics, and he never says no. So I really like the way he looks at all the things without, and asks a lot of questions to himself and then brings the easiest way to portray those things to us. So probably that's the criteria of when I started choosing people for this particular course. That's what I was looking for, people who can make things easier for everybody to understand. And I know that he'll do his the best he can in making this dry subject as interesting as possible. So over to you, Dr. Praveen. Thank you for joining us, and thank you for obliging us with your lecture. Let's start now.
Thank you, Dr. Neha. I just want to confirm that my voice is very clear,
It
right?
is. It is. It's perfectly clear, and we can even
Yeah.
see your slides.
So,
Yeah.
thank you. Thank you for that nice introduction. So today we are going to discuss about B-cell immunodeficiency disorders. The objectives are to know when to suspect a possible B-cell immunodeficiency disorder, how to diagnose it, how to treat it. So what's the big deal about the B-cell immunodeficiency? We all kind of know that patients, whoever comes to our OPD with a history of recurrent infection, we'll have a possibility of immunodeficiency disorder in the background. And whenever we think about a possible primary immunodeficiency disease, first thing we will do is we will send immunoglobulin levels and CD4 and CD8, because that is something which we can do easily. And if the immunoglobulin levels are low, you kind of know that it is probably B-cell immunodeficiency disorder, and it's very kind of easy to diagnose. We also know that the most common immunoglobulin deficiency disorder which you see is a common variable immunodeficiency. It can present in adults also, but in childhood, usually first 6 months, the child is protected by immunoglobulins which are coming from the mother. And after 6 months of age, you'll start seeing the child getting recurrent infections, which is a very classic history. And these infections will be usually on the mucosal surfaces, which are kind of exposed to a lot of foreign antigens and foreign microorganisms like sinonasal infections, pulmonary infections, and recurrent diarrhea. And once you diagnose a patient with immunoglobulin deficiency, the treatment is treat the infection, put the patient on antibiotic prophylaxis, and give the patient intravenous immunoglobulins, because that is what is deficient. And for each patient, we try to kind of maintain a trough level of IgG where the patient is not getting any further infections. Usually something more than 400. Some people we have to target kind of more than 800. However, these primary immunodeficiency disorders are little rare. Even in our OPDs, in adult OPDs at least, we kind of see probably a couple of cases, not more than 5 cases in a year. So it is kind of a rare disease. The primary immunodeficiency disorders as such are very kind of rare only. Even though if you make them cumulative together, the number might look bigger. But we all know that in our routine OPD practices, unless we are really running a primary immunodeficiency clinic, we won't see that many primary immunodeficiency disorders. So why should we really worry about a disease which is kind of very rare and looks very simple, right? There is immunoglobulin deficiency, you give immunoglobulins, and the treatment of infection is no different from other patients, and probably you have to put the patient on prophylaxis. There are two important reasons why we should discuss B-cell immunodeficiency disorder. Reason one, it might look very simple that we are giving just IVIG and patients will not develop further infection, but that is not true. Many of the times we fail to follow these patients for years together. But when, for example, if a patient is presenting in early 20s, the mortality by the age he reaches 40 is quite high. So many of these patients might die because of infective complications, might die because of the complications which are not related to infections, something like autoimmunity or autoinflammatory complications or end organ damage. Second important reason is primary immunodeficiency disorders are nature's experiments to teach us immunity. And this is very, very important. It is similar to why MD medicine resident is getting rheumatic heart disease as a case for the presentation in the final exam? The answer is only if you understand the RHD, you will understand the hemodynamics of cardiology. Similarly, only if you understand the primary immunodeficiency disorders, we keep on giving so many biologicals to hit T cells, B cells, Janus kinase pathway, and we will only understand if you really understand the primary immunodeficiency disorders associated with that, and we'll kind of know what kind of infections we can expect if you are treating a person with some biological. For example, let us look into the B cells only, because that is the topic today. So you can see that CD19 is expressed from pro B cell up to plasma cell, whereas CD20 is expressed from pro B cell but not in the plasma cell. So if, and you can see BCMA and CD38 are expressed exclusively on the plasma cells. So if you want to really target a B cell lineage, especially in the leukemias, if you want to really target a lymphoblastic leukemia, you want to kind of give a monoclonal antibody that is against CD19. Similarly, CD20 monoclonal antibodies like rituximab, which we keep using in rheumatology, even in oncology, sometimes in hematology, and all the transplant settings, this is one of the most common monoclonal antibody which will target CD20. And daratumumab, very specific for plasma cells, we use it in multiple myeloma. Similarly, we also use some other monoclonal antibodies targeting something like BAFF and BCMA. BAFF is BCL activating factor. This is expressed exclusively in early plasma cells, whereas BCMA is expressed in the late plasma cells. So BCMA is very, very specific for plasma cells. So if you want to treat a multiple myeloma, probably you want to target BCMA. So there are a lot of monoclonal antibodies against these factors. For example, belimumab, which is used in lupus nephritis, which is found to be beneficial in lupus nephritis, is a BAFF inhibitor. It's predominantly inhibit the soluble BAFF. Whereas you have a lot of bispecific like teclistamab, elranatamab for the treatment of multiple myeloma. We also have CAR T cells. CAR T cells are chimeric antigen receptor T cells, and the receptors are directed against BCMA. That is idacabtagene and ciltacabtagene. So these are the biologicals we keep on using day in and day out, and this is not very rare. So once you understand primary, for example, BAF mutations in BAF can lead to CVID. So once you know what is happening in this patient of CVID, who is where there is a mutation in BAF, you already know what is going to happen when you are giving belimumab in a patient with lupus nephritis. So this is how we kind of understand the secondary immunodeficiencies better when we have a clear idea about what is primary immunodeficiency. So today we are going to have a little bit of recap of immunology. I will also discuss a little bit of B cell development. These two are already been discussed in the past extensively, but I will just simplify it, discuss few points which are important for you to understand the subsequent sessions of the presentation today. We'll also discuss about patterns of infections. This is very important because I'm an ID physician. I will try to tell you what kind of infections will actually tell you that this is possibly an immunoglobulin deficiency, not a phagocytic defect or not a T cell immune defect. We'll also discuss a little bit about monogenic disorders. These are briefly mentioned in the previous classes. And we'll also discuss about management, not just management of infections, not just management of heart inflammation, but we'll also look into some of the end organ damages and how we can manage this and what is the role of hematopoietic stem cell transplant. So even though the topic given to me is B cell immune defect, most of the times everything comes together. So we have to kind of discuss again a little bit brief on about whatever the immunology which we have been already discussing in the past 3-4 classes. So the major important thing about immunity is immunotolerance. If your immunity persistently active, it will either lead to autoinflammation, autoimmunity. It also can lead to exhaustion, which can lead to again recurrent infections. So the most important part of human immunity is immune tolerance. We are exposed to so many antigens through the lung, through the gut, day in and day out. There are a lot of mechanisms in our body, like barrier immunity. We have discussed about antimicrobial peptides like cathelicidins, beta defensins, alpha defensins, SPA, SPD. And we also have very specialized kind of macrophages in tissues. Like in lung we have alveolar macrophages. So whenever there is some antigen, alveolar macrophage will eat it, and that's it. It will not give a present this antigen to the dendritic cells or T cells to stimulate immunity. Most of the times it is dead. The immune once there is an antigen taken care by alveolar macrophages, that's it. Otherwise, each antigen, if your alveolar macrophages keep presenting to dendritic cells and T cells, that will lead to long-term inflammation and fibrosis of the lung, which is not happening. Similarly,
Praveen,
liver.
uh, Praveen, I'm so sorry to interrupt. There is a pop-up on the your screen. Can you just stop it?
Sure.
Hide.
Yeah.
Yeah. Thank you. Thank you.
Sorry for that. Yeah. So Kupffer cells again in the liver, a lot of endotoxins from the gut, a lot of bacteria are going into the liver, and liver might not have to respond to everything. So you have kind of a specialized macrophages in the all these tissues, like oligodendrocytes in your brain. Again, brain immunity is a separate section. Then again, you have some intracellular mechanisms, most importantly autophagy. Once the antigen is taken into the phagocytic cell, most of the times there won't be any adaptive immune stimulation because the autophagy will take care of it. Then even in intracellular signalings, which we have discussed, finally they land up in one of the three pathways: NF kappa beta inflammasome pathways or interferon IRF3 and 7, which we have discussed. And the defects in this can lead to autoinflammatory syndromes, and they kind of regulate each other. For example, if you have a viral infection, that will lead to interferon signaling, and IRF3 7, which are stimulated there, will actually inhibit NF kappa beta. So for example, you have a dengue, you don't see a surge of interleukin 6 and elevation in CRP. You rarely see that dengue fever is causing elevated CRP. If dengue fever is causing elevated CRP, that means the interferon signaling is not right and the patient is going to become sick. So high IL-6 might be a poor prognostic indicator, but most of the times in viral fevers, you don't see a high IL-6 or high TNF alpha. What you see is a interferon signaling, and interferon gamma in particular will actually inhibit CRP. So dengue fever, you don't see high CRP, but if there is an increased CRP, it is a poor prognostic indicator. Again, this NF kappa beta pathway and IRF3 are self-regulated. You have some of the molecules which inhibit NF kappa beta, A20, which we have discussed about haploinsufficiency A20 and autoimmune deficiency and Leubat deficiency, which Dr. Abhishek had discussed in the last class. And again, IRF signaling is again inhibited by something like SOX1, and haploinsufficiency of SOC1 can actually present like interferonopathy. So what I'm trying to tell you is there is a balance at each point of time. The inflammation in the body is getting checked. So if you have any other pathways which counter-regulate each other, please post in the chat box. We'll discuss about that in the end. This is about autophagy. To simplify it, there is a debris or some antigen inside the cell. The autophagosome will take it and it will fuse it with lysosome, which will form autophagolysosome, where enzymes will digest the antigen, right? Now, this is very important, especially for the brain, because you cannot have a adaptive immune response in the brain that will lead to encephalitis, and brain cells cannot have an inflammasome pathway, which will lead to necroptosis or apoptosis. So brain cells cannot die. So the most important mechanism of dealing infections in brain is actually autophagy. And just imagine some infection which hijacks autophagy. For example, rabies. Rabies induces autophagy, induces the formation of autophagosome, but inhibits the formation of fusion of autophagosome with lysosome. So it's a catch-22 situation. So that is the reason why it is very difficult to eradicate rabies, and mortality is almost 100%. So if you're trying to treat rabies, probably we have to focus on inducing autophagolysosome formation. If you know any anti-epileptic drug which increases the autophagolysosome formation, please put it in chat box. Again, we have already discussed about toll-like receptors. For example, toll-like receptor 3 again is highly expressed in the brain. And if there is a hypomorphic mutations in toll-like receptor 3 or hypofunctional mutation, that will lead to herpes encephalitis. TLR7 and TLR9 they regulate each other. If you have a decreased TLR7 signaling, you'll have a very bad form of viral infections, for example, COVID. But at the same time, increased TLR7 expression can lead to something like a lupus phenotype. And toll-like receptor 9, they will regulate TLR7 signaling. So if you have a hypomorphic mutations in TLR9, again, that will lead to a lupus-like syndrome. So there is a very interesting way how the things are regulated, and in each point of time you have multiple checkpoints, and any of them can actually lead to something we are discussing today. It can eventually land up in uh, B cell deficiency. So once let us look into how body reacts to a pathogen. So if there is an intracellular pathogen inside the body, let us assume that this is a terrorist, Osama bin Laden, inside your house. There are 4 people inside your house who can take care of it. One is father, That will give us, let us assume that it is a pattern recognizing receptors. So all the toll like receptor, sig like receptor, nod like receptor eventually lead to the signaling of NF kappa beta or interferon signaling, which is kind of mature signaling. Once you have interferons will lead to interferon signaling gene, and interferon signaling genes will actually splice the RNA or DNA which is there in the cytosol. So again, here you are not taking the help of adaptive immunity. You are trying to take care of by yourselves. There is another mechanism called PKR signaling, where host will switch off the translation so that the viruses cannot use the host proteins. And there is another mechanism by which host will deal with intracellular organism is inflammasome pathway. It is associated with some tissue damage. And one of the mature mechanism again is chop the viral antigen or any antigen, intracellular antigen, put it on MHC and present it to adaptive immunity, which includes T cell immunity and B cell immunity. So this is where actually adaptive immunity is coming. So a lot of things are already happening in the body, trying to take care of any foreign antigen by themselves. And finally, if you are not able to take care of themselves and need some help, they are asking the adaptive immunity to help, and that is through MHC. Sometimes, some of these adaptive immunity arms are corrupted, like antibodies, and that can actually lead to something like antibody mediated enhancement of the disease, like in dengue, what we see, right? And we have discussed about a lot of cytokines. All the cytokines are interferons and interleukins. So all the tins and ters. For example, if you ask what is the translate how prolactin is acting through the intracellular signaling, so that will be prolactin. It is tin, so it's a JAK-STAT pathway. So there are lot of molecules of JAK and STAT. We will not discuss everything in detail, but we have a lot of molecules to block this JAK-STAT pathway. For example, JAK1, JAK3 inhibitor, tofacitinib, which we are kind of using it regularly. You have a JAK1, JAK2 inhibitor, baricitinib. You have JAK2 predominant inhibitor, something like ruxolitinib. These are the molecules which we keep using in our daily, day in and day in practice. And some of these mutations can actually lead to primary immunodeficiency. For example, JAK1, JAK3 mutation is SCID, and this JAK signaling happens through the STAT pathway, and the STAT one is more of a TH1 pathway. We have discussed about the STAT1 deficiency leading to Mendelian susceptibility for mycobacterial diseases. At the same time, STAT1 hyperactivity will lead to increased TH1 signaling, but that will eventually inhibit TH2 and TH17. So these are again antagonistic to each other. If your immunity is deviated to TH1, you will have TH2 deficiency and TH17 deficiency. That's the reason why when you have a STAT1 gain of function mutation, you kind of develop fungal infections like Candida in patients with STAT1 gain of function mutations. Similarly, you have a STAT3 gain of function mutation, which is one of the type of CVID. Now you see that CVID, when we are going to discuss about a common variable immunodeficiency, there could be a mutation like STAT3 gain of function mutation, which is going to pop up suddenly. And then it will be a little difficult to understand what is happening. That is the reason why I'm giving this introduction to this topic. So it is important because some of these diseases can actually be dealt very well with a JAK-STAT pathway inhibitor. For example, STAT1 gain of function mutation, you can give ruxolitinib, that will actually decrease the Candida infection. If I tell you something like patient with Candida, I want to give ruxolitinib, you might feel that I'm mad. But in this particular situation, the STAT3 inhibition is because of STAT1 gain of function. So if you bring down the STAT1 signaling a little bit down by giving one of the JAK inhibitor, like ruxolitinib, then your STAT3 will come back. So there is a more antifungal, extracellular antifungal immunity once you give something like ruxolitinib. Similarly, STAT6 gain of function mutation can lead to something like hyper IgE syndrome. That will be associated with TH17 deficiency. That will be associated with fungal infections. And once you give a JAK-STAT pathway inhibitor, everything will settle down. Similarly, a STAT3 gain of function mutation associated CVID can be treated very specifically by using JAK-STAT pathway inhibitors. Okay. So in summary, once the pathogen enters, body will try to not to stimulate the adaptive arm of immunity. But if innate arm requires help of adaptive arm of immunity, antigen presenting cells eventually ask naive T cells to help. They will differentiate into TH1, TH2, TH17, T follicular helper cells. Follicular helper cells are very specific type of T cells which will go to the lymph node, where they will help for the T cell activation, proliferation, and differentiation. So what I'm trying to tell you is, if you're talking about a B cell immunodeficiency disorder, the disorder might be at the level of B cell activation, proliferation, and differentiation, but it can also be there at the level of T cells and the signals which are leading to the T cell stimulation. So long story short, we are going to discuss about B cell immunodeficiency disorders. So we have discussed that B cells are very professional antigen presenting cells, but we have to understand that they are just antigen presenting cells. They are not phagocytic cells. So in the phagocytic cell defects, we discussed about how the macrophage creates a oxidative stress, generates hydrogen peroxide, generates myeloperoxidase to kill the bacteria inside the cell. B cells can't do that. So B cells can't kill tuberculosis inside the cell, right? So B cells are just antigen presenting cells. They will take antigen from dendritic cell, they will present it to T cell, show it to T cell that they see I have this antigen, but they cannot kill the cells inside them. Not very efficient way. So if the B cells are actually trying to behave like antigen presenting cells, for example, in hairy cell leukemia, B cells will have a lot of hairy projections, very similar to dendritic cells. They will also express something like cluster differentiation factor 11C, which is a complement factor which can be utilized by some of the organisms to enter into the cell. Hairy cell leukemic cells are actually sanctuary site for a lot of infections. So in patients with hairy cell leukemia, once you give chemotherapy, suddenly you see that patient is having disseminated tuberculosis. Once you kill this hairy cells, then you see all the intracellular organisms which are lying there inside the B cell, suddenly they disseminate, right? So it is important to understand B cells are good antigen presenting cells, but not phagocytic cells. So let us briefly look into the development again. So B cells, they come from bone marrow, where pro B cells will become pre B cells. Pre B cells will get a degree called matriculation IgM, where they will become immature B cells. Once they got diploma called IgD, they are left from bone marrow to enter into the lymph node. In the lymph node, again, B cells interact with dendritic cells. Dendritic cells also interact with T cells, and T cell B cell will also interact. And this interaction at the T cell B cell border is very, very important, because it is where the fate of B cell, whether to go into germinal center or not, is decided. So if you have any defect of B cell interaction with follicular hyper cells at the B cell T cell border, there is no migration of B cell into the germinal center itself. So what you see is uh, the patient will not have germinal center B cells, where somatic hypermutation and class switch recombination will happen. So they cannot produce IgG, IgA, and IgE. They will be only producing IgM. And at the same time, because there is no B cell entry into the germinal center, you will not see lymph node enlargement. So this is the classic hyper IgM syndrome, which is associated with CD40/40 ligand. Again, in germinal center, there is something called somatic hypermutation, class switch recombination, which we already discussed. And finally, the fate of B cell is to become a switched memory B cell or plasma cells. So this is what we are discussing about the immune synapse between follicular T cells and B cells, which is happening at the T cell B cell border. You can see that B cell is expressing CD40, and CD40 ligand is there for T follicular helper cells. This interaction is very, very important for the B cell survival, entry of B cell into the germinal center. But at the same time, you can also see there is a ICOS ligand presented on the B cell surface. ICOS is there in the T follicular helper cells. This interaction is very, very important for follicular helper cell survival. So they both are interdependent, and if this interaction, any defect in this interaction is happening, there won't be formation of germinal center, and there is going to be antibody deficiency. A similar interaction again happens in the light zone of lymph node, which we will also see in the future slides. Okay. So this is somatic hypermutation. When someone shows me this, I will not understand anything. I'm an ID physician. I don't care about how this combination of things are happening. For me, it is very easy. If there is a change, mutations happening in the variable region, that is to have more antigenic variability of the B cell. This is somatic hypermutation, which happens in the dark zone. And if there is a change in heavy chain, this is class switch recombination, where IgM will become IgA, D, or E. IgM will become IgG, A, or E. Sorry. So this is class switch recombination. So somatic hypermutations happens in the light dark zone here, and the class switch recombination happens in the light zone. Again, here it is very interesting. So it is more like a student who entered the college, and in dark zone he can do whatever he wants, but at the end he has to give an exam. So whatever he wants is somatic hypermutation. You can mutate the way you want to become more efficient, but once it is done, you have to go to light zone and present your antigenic affinity, like antibody affinity, to the follicular helper cells. So there will be again some antigens presented by follicular dendritic cells to B cell, and B cells will take that antigens, take it on to the MHC complex and present it to follicular helper cells. And based on the affinity of this antibody to particular antigen, the T follicular helper cells will decide whether the B cells should go apoptosis, or should it go back again to the dark zone to have a more somatic hypermutations, or is it good for formation of switched memory B cells or plasma cells? So if there is a good interaction between T follicular helpers and B cells, there will be higher c-MYC expression that will lead to B cell differentiation into plasma cells and switched memory B cells. Now this is very interesting because this is something happening in the light zone, and some of the viruses like Epstein-Barr virus, they hijack this. So here again, you can here again in between T follicular helper cells and B cells, the CD40-40 ligand interaction is very important. And what EBV does is EBV gives a false signaling to the B cells that you can actually proliferate. It is more like it says you can actually proliferate despite of no signals from the follicular helper cells. That will lead to actually lymphomas. This is the lymphomas which are happening in the germinal center, which we call it as latency stage 2. And most of the non-Hodgkin's and Hodgkin's lymphoma related to EBV are because of this CD40-40 ligand interaction in the light zone of the lymph nodes, right? So this is it. To simplify it, T cell B cell border, follicular T cells will allow the B cells to go actually to the germinal center. In the dark zone, you undergo somatic hypermutation for the antigenic variation. Then you go to the light zone, where based on the signals from dendritic cells, follicular dendritic cells, and follicular T helper cells, it will switch into switch memory B cells or plasma cells, which are expressing IgG, A, and E. So let us look into what are these immunoglobulins again briefly. So IgG immunoglobulins, again we have discussed about IgG subtypes. There are IgG1, IgG2, and IgG3 and IgG4. Okay, so immunoglobulin are important for three important functions. One is four important, probably five. So one most important three functions are probably complement dependent cytotoxicity, antibody dependent cytotoxic immunity, or opsonization. So you can see that IgG1 antibodies have strong CDC activity and strong ADCC activity. IgG2 they have very poor CDC and ADCC, and IgG3 you can see very short half-life, and IgG4 they do not have any complement dependent cytotoxicity, ADCC, or opsonization. These properties of IgG antibodies, subclass antibodies, we are actually using them to make monoclonal antibodies, right? So if you want to really make a monoclonal antibody to kill a cell, it should either have a good complement dependent cytotoxicity or antibody dependent cytotoxic immunity. So you really want to make a IgG1 antibodies to kill cells. For example, you want a rituximab. Rituximab is an IgG1 antibody. Whereas you don't want to use IgG2 and IgG3 for the reasons because IgG2 doesn't have good CDC, ADCC. IgG3 is a very short half-life. It will be cleared very quickly. What about IgG4? IgG4 are very interesting antibodies that they bind. They will not activate ADCC or CDC. So you will not see something like cytokine storm after starting IgG4 antibody, but they are more like not to kill the cells but block the receptors. For example, something like PD1 and PDL1 blockers, checkpoint inhibitors we use. This is very important and interesting because if you have an antibody like rituximab has a predominantly complement dependent cytotoxicity, little bit less of antibody dependent cytotoxicity. So in a case of lupus, if you want to treat the patient with rituximab, if there is not enough complement, the patient might not respond. Now, one of the clear example is Luna trial, where people compared standard of care plus rituximab with standard of care, and the trial failed miserably. One of the post hoc analysis actually says that the patients where you are able to kill the B cells, they have actually responded, but people where there is no B cell depletion, they're not responding. What is the reason for not having B cell depletion? That's because lupus, you frequently see there is a complement deficiency. I'm not saying it will not completely work, but if you have an antibody which depends more on ADCC rather than complement dependent cytotoxicity, it might work well. And that antibody is obinutuzumab. You have a recent trials with obinutuzumab. One is phase to nobility. Recently in February 2025, you have recency trial, and you can clearly see this trend that these patients are doing better when they're combined with the obinutuzumab along with standard of care versus just standard of care. Again, this pattern we also see in patients with hematological malignancies. So right now we are not discussing it much, but I'm very sure in future we'll be discussing about complement levels to assess the response to rituximab. What about IgA? IgA are two types. Our interest is in secretory IgA, which is secreted in the mucosal surfaces. Now, IgA is very very interesting, especially in the gut epithelium, because gut is something which is constantly exposed to different antigens. So, what IgA is doing is IgA is preventing any microbe or antigen for that matter to reach epithelial cells. So there are specialized cells in the gut which keep on sensing signals from epithelial cells to ask whether you are doing okay or not, and epithelial cells constantly have to tell the dendritic cells that we are doing okay, don't worry. So if the by secreting some factors like retinoic acid, but if epithelial cell damage is there, that signal is not there for dendritic cell, which eventually lead to activation of adaptive immune system, leading to something like IBD. Now, this is very important because this keeps happening in CVID, where we see IgA deficiency along with IgG. So there is some epithelial damage, and then eventually lead to autoinflammatory like condition in patient's gut, which will sometimes mimic like a celiac disease. We'll discuss about that. Sometimes mimic like a chronic inflammatory bowel disease. So this IgA is very important, and they kind of neutralize the harmful bacteria, so that will lead to actually growth of more commensal bacteria. So once you have IgA deficiency, one thing is leading to chronic inflammation, but at the same time it is also leading to change in gut microbiota. So if you're seeing a patient with CVID with a lot of gastrointestinal symptoms, it is not just about treating the inflammation. Probably by that time the patient's gut microbiota is also a little bit changed. Probably the future targets will be gut microbiome also. What about IgM? IgM is again very very interesting antibody. It has good neutralizing potential, but the molecular size is so big that it actually cannot have tissue penetration. But it is very strong in a way that it activates the complement. Now, for something like a capsulated bacteria like pneumococcus, so pneumococcus or Haemophilus influenza, Moraxella catarrhalis, these are capsulated bacteria, and this capsule actually prevent the effective phagocytosis. So you need something to help neutrophils or something to help to the complement. So this IgM actually coats onto the bacteria, and that will help in complement dependent cytotoxicity. That is the reason why if you have a IgM deficiency or complement deficiency, you tend to have infections with capsular organisms. Now this is the structure of spleen. You can see this terminal arteriole. Along the terminal arteriole, there is a perilymphatic sheath of T lymphocytes. And sometimes when there is a proliferation of perilymphatic T lymphocytes, something in lymphoma, that will look like a microabscess in an ultrasound. And also there is a specialized zone called marginal zone. This is very, very specific to spleen. In the marginal zone, there are marginal zone B cells, which are very, very rich in IgM. So the moment there is something like pneumococcus, the marginal zone B cells are going to release a lot of IgM, which will lead to complement dependent cytotoxicity of the pneumococcus. So if you remove the spleen is a lymphatic organ, but it is not just any other lymphatic organ. Most of the lymph nodes in your body, they're kind of looking into the surrounding areas, into the tissues, epithelium, whether there's something is going wrong. But spleen is kind of filtering the blood. So if you have removed the spleen, there are no marginal zone lymph nodes, no IgM, then this is the patient who is going to develop a bad pneumococcal sepsis. In fact, in pneumococcal pneumonias, we frequently see if the patient is admitted with a severe pneumococcal infection, if the IgM levels are very, very low, that indicates poor prognosis. So the trials there now, for example, the Sigma trial, for example, they are looking into IgM rich immunoglobulins, because normal IVIG has predominantly IgG1, a little bit of IgG2, almost negligible IgM. So you want something like which is a high IgM rich pneumococcal, IgM rich IVIG, rather than just intravenous immunoglobulins we routinely give for the treatment of these severe infections. What about Ig? We all know about Ig. Ig will eventually lead to mast cell degranulation or eosinophilic degranulation. Very, very important. Very, very important in allergic manifestations. And we have very specific monoclonal antibodies to target Ig, interleukin 5 and interleukin 4, 13. For example, mepolizumab, omalizumab, dupilumab. So these are the things which we keep doing day in and day out, creating artificial secondary immunodeficiency, and which are very, very important to know and treat, and very frequent, and that we can do only if we understand the primary immunodeficiencies in proper. So finally, to the topic proper, B cell primary immunodeficiency disorders. So we are going to discuss about first about the empty arsenal. The empty arsenal is nothing but A gamma globulinemia. We call it as X-linked A gamma globulinemia, but it can be autosomal recessive also. So if you have a female patient looking like A gamma globulinemia, think about a possible autosomal recessive, and that is not because of the mutations of BTK, but that is because of the mutations in pre-B cell receptor complex or something called blink. So we have discussed it again in marrow. Pro B cells will become B cells, pre B cells, and from pre B cells to become an immature B cells, there is a checkpoint. The pre B cell receptor has to be able to signal through BTK. If that signaling is wrong, there won't be formation of B cell receptors, and there is a complete arrest of B cells in the marrow itself. So when we are saying A gamma globulinemia, it is not just hypogamma or lack of antibodies, but you'll also not have B cells in the peripheral circulation. This is the most important difference between A gamma globulinemia compared to hyper IgM syndrome and CVAD. You will not have peripheral B cells, neither you will have immunoglobulins. This happens with BTK mutations. Must be very rare. Antibodies, again, first 6 months patient can be protected, but eventually they'll end up in recurrent infections. So we can diagnose this by sending immunoglobulin levels, which will be very low. And if you do a flow cytometric analysis, and then B cells will be very low. If you have really doubt, you want to assess the function, you can also look at the BTK expression on the monocytes and platelets. This is important because BTK is not just important for the B cell maturation, but it is also important for something like monocytes, neutrophils, and platelets, right? The treatment is a supplementation of immunoglobulins, antibiotics. We want to give vaccination. We don't know how much the immune response will be. Right now, there is no gene therapy and allogenic stem cell transplant you can do. We'll discuss about these things a little more in the later chapters. So why, again, this might seem a very rare possibility, especially someone like me who is an adult ID physician. Hate to see pediatric patients in OPD. I might not see this in probably, unless I'm forced to see, probably I will not see the X-linked A gamma globulinemia in my outpatient department. But what I'm going to see commonly is patients who are on BTK inhibitors. Now you see there is BTK, which is important for the activation and proliferation, survival of the B cells. And we are giving something like BTK inhibitors day in and day out for so many patients with the non-Hodgkin's lymphoma or chronic leukemias, most importantly, ibrutinib. So we all know that ibrutinib causes fungal infections. The patients who are on ibrutinib, we give prophylactic antifungals. But interestingly, patients with X-linked A gamma globulinemia, we are not seeing these fungal infections. They are historically X-linked A gamma globulinemia will characteristically present with some of the bacterial and viral infections, but not with fungal infections. Whereas when you are giving ibrutinib, patients are developing fungal infections because we know that BTK is not only important for the B cells, but it is also important for neutrophils, macrophages, and patients with X-linked A gamma globulinemia who are congenitally deficient in BTK, the other pathways in macrophages and neutrophils will take care of. They compensate for it. Whereas if the patient we are giving external BTK inhibitor, suddenly all this BTK signaling is switched off. Patient can land up in neutropenia, monocytopenia, and they are very prone to develop fungal infections. Quiz question: a patient on ibrutinib, which of the following is more likely to be an infection rather than relapse of a lymphoma? Is it a intracranial space occupying lesion? Is it a pleural effusion? Is it a testicular mass? Or is it ocular lesion? So put your comments in the chat box. Let us go into the other primary immunodeficiency disorder, which is hyper IgE syndrome, hyper IgM syndrome. We have discussed about it. The two important hyper IgM syndromes are, one is CD40-40 ligand interaction, which happens in the B cell T cell border before the B cell enter into the germinal center. So that is the reason why you will not see a lymphadenopathy. You will not see lymph nodes being enlarged. You see patients with IgG-AE deficient, IgM will be elevated, and these are the patients, again, they are prone to not only classical infections associated with immunoglobulin deficiency, because this CD40-40 ligand interaction is also important from the macrophages to T cell interaction also. So these patients can actually develop other infections which are more characteristics of T cell immunodeficiency. Ideally, it should be classified as a combined immunodeficiency, but there is again a lot of overlap in these things. So T cells, these are the patients who will not have immunoglobulins. Again, there is low lymphadenopathy. Whereas there is another hyper IgM. There are many hyper IgM syndromes. The most common is these two. One is the AID deficiency. AID is nothing but the enzyme which is important for somatic hypermutation and class switching. So this is the B lymphocyte which is already entered into the germinal center, right? It is not getting enough somatic hypermutations because of the deficiency of activated cytidine deaminase, and it is not able to undergo class switch. That is the reason why all the B cells, they are proliferating, they are in the germinal centers, but they are only producing IgM. They are not able to switch to IgG, IgA, and IgE, and at the same time they are not having an antigenic diversity which is expected after somatic hypermutation. So these are the patients will again develop variety of infection. But in these patients, because there is an excessive proliferation of B lymphocytes in the general centers, you will actually see lymphadenopathy as well as autoinflammatory symptoms. So that is the basic difference between two most common hyper IgM syndromes. So in clinical practice, why it is important? Because you day in and day out, you see a lot of lymphoma patients, tuberculosis patients. Some of the patients' lymph nodes are actually calcified. So the stroma of the germinal center of the lymph node is completely gone. So these are the patients, they will frequently having a high globulin levels, total globulins. But if you do a immunoglobulin levels, you might sometimes find that the IgM levels are elevated, but IgG, and are less. And these people are prone to recurrent infections with many other bacteria. So you can try looking into it. And BCL6 again is BCL6 is very important again for the maturation of switch memory B cells, for the maintenance of germinal center. And BCL6 is an important mutation in variety of malignancy. Till now, we don't have a BCL6 inhibitor. Probably in future, we might have a BCL6 inhibitor, and the infections associated with it is what we can see. So coming to the last and the most vast topic, the common variable, and a lot of confusion, confusion causing immunodeficiency. So most important thing is, many of the times, even though we try to put it in the brackets of B cell immunodeficiency, they can have associated T cell disorder. Sometimes when you're seeing the patient, initially he'll be only isolated B cell immunodeficiency with low immunoglobulins. But if you follow them for years, then you kind of see that patients also dropping the CD4 and CD8 counts. It could be because of the inflammation and exhaustive phenotype and apoptosis which is happening in the T cells. Whatever is the reason, it could be genetic cause which is expressing in the later part of the life. This we put in a bracket of late onset combined immunodeficiency. And sometimes this CVID is associated with immunodysregulatory syndromes. I think there is a separate topic of immunodysregulation in the few coming classes. But as I told you, there will be a lot of overlap between the topics, and I will try to put an angle from an ID physician rather than really going into the immunodysregulation part. So there is a criteria to diagnose CVID. Once you have criteria to diagnose any disease, you have to know that it is not straightforward. One of the criteria is you either have to have a recurrent infections or autoinflammatory syndrome, autoinflammatory manifestations or autoimmune manifestations, or something like granulomatous disease, which we will discuss shortly, along with IgG deficiency with either IgM or IgA deficiency, excluding secondary causes of hypogammaglobulinemia, something like biologicals, also excluding profound T cell deficiency, which will fit the patient into severe combined immunodeficiency. And these infections should be established after fourth year of life, because there is another entity called congenital transient hypogammaglobulinemia, which will be usually reverted between 2 to 4 years. So it's a kind of, you have to kind of exclude everything. And if you are seeing antibody deficiency and recurrent infections or autoimmune manifestations or granulomatous disease, probably you are looking into CVID. So again, we have discussed about multiple interactions between T cell and B cells. You can see that this is the CD19 2081 is a B cell receptor co-stimulation of B cell receptor. So there can be mutations here. Most common genetic mutation associated with CVID is TASI, which is expressed in the plasma cells. Again, not all patients with TASI mutations will have CVID. We don't know exactly how it works, but it is kind of expressed in early plasma cells and late plasma cells. Again, you have BCMA associated mutations, and you have BAF and BAF receptor associated mutations, which can lead to immunoglobulin deficiency. Very interestingly, some of the disorders which will have more of a immunodysregulatory syndromes, like a CTLA4 haploinsufficiency, which we call it as CHAI, and then there is a LRBA deficiency haploinsufficiency, which we call it as LATE. So both chai and latte, they are forms of CVID associated with a lot of lymphoproliferation, splenomegaly, autoimmune cytopenias. Again, there is another deficiency called P3 kinase delta or gain of function mutation. In fact, where the lymphocytes will keep on proliferating, they undergo immune exhaustion. So you have a abnormally high number of lymphocytes which are abnormally functioning, producing not producing antibodies, but producing whatever antibodies they're producing are leading to autoimmune cytopenias or autoimmune disease. So these are some immune dysregulatory syndromes which are again kind of put in the bracket of CVID. We'll specifically discuss about them also. So if you're looking into a CVID patient, there are four different phenotypes. One is infection predominant phenotype. Now these are the patients who land up in probably in infectious disease OPD, and they will have a better prognosis. They are kind of simple and easy to manage, but most of the times about one third of those patients will actually have other phenotypes, that is autoimmune cytopenia phenotype, where patients will have refractory cytopenias labeled as event syndrome, and then suddenly patient develops some infections which you are not expecting. So the patient was diagnosed as event syndrome, but rheumatologist will always feel that there is something not right about this disease. There is splenomegaly, even though patient is having ITP, and then suddenly patient develops an opportunistic infection which you are kind of not able to explain with the amount of immunosuppression you are giving to the patients. So this is one phenotype which will land up with a rheumatologist. Then you have a chronic enteropathy type of phenotype where the patient will keep on having diarrhea, and they will land up with gastroenterology, where they'll be where trying to diagnose it, labeling it as CLD, Crohn's disease, ulcerative colitis, microscopic colitis like lymphocytic or collagenous colitis, or bacterial overgrowth. Most of these patients will also have bacterial overgrowth. And then there is a lymphoproliferative phenotype, which who will be roaming around with rheumatologist and hematologist, lymphadenopathy, hepatosplenomegaly, some lung involvement, biopsy showing biopsy is not specific for any lymphoma, and everyone is confused. Many times, all these things can happen together. So the same patients can have chronic enteropathy and autoimmune cytopenia and lymphoproliferative phenotype. This overlap can also be seen. Let us look into few immunodysregulatory syndromes. We are discussing about this CTLA4. CTLA4 is a immunological break in the immunological synapse. So excessive activation of T cells is prevented by CTLA4, but at the same time, CTLA4 inhibition is also important for B cells. Otherwise, there will be dysregulated B cell proliferation, leading to excessive follicular helper T cell signals. So this can lead to autoimmune cytopenia or lymphoproliferative type of phenotype, often associated with chronic CVID enteropathy. Again, this is called APDS. APDS is because of the gain of function mutations associated with P3 kinase. Again, it will lead to excessive lymphoproliferation, but patient will have autoimmune manifestations in the presence of lymphopenia. Again, this patient will present with a very similar phenotype. And the treatment of this, most of the time, these patients were kept on steroids, but they won't respond that well. Sometimes we kind of give the patients immunosuppressants which will kind of a blanket immunosuppression, probably reduce the proliferation by giving mTOR inhibitors. But if you are able to diagnose, for example, this CTLA4 haploinsufficiency, you can actually give a very specific monoclonal antibodies which are CTLA4 agonists, which is nothing but abatacept, which you can actually use upfront, so that the patient will go into remission. Then probably you can switch into a long-term oral therapy, something like mTOR inhibitors. Similarly, for P3 kinase gain of function mutations, we have very specific molecules which we are using in medical oncology already, which are P3 kinase inhibitors. So it is very interesting, you are using all this already in some other setting, where you have to bring that and understand and give to the patient who is suffering with APDS. So leniolisib is one of the P3 kinase inhibitor, which is very approved for the treatment of APDS. But we commonly use idelalisib, dualisib in the patients in malignancies. These inhibitors, again, you can see that the P3 kinase signaling is eventually landing up into the mTOR pathway. So probably giving mTOR pathway inhibitor, something like everolimus or sirolimus, might also be helpful, especially once you gain kind of remission after treating with initially with a P3K delta inhibitors. You can switch the patients into the sirolimus. But however, these are the genes which are quite recently detected. P3 kinase deficiency actually is detected when I joined my MD probably a decade ago. So we don't have any long-term follow-up of these patients who are put on this very specific um, pathway inhibitors. Probably these can be very well used for the optimization of immunodysregulation before taking the patient to the transplant. Again, NF kappa beta pathways we have discussed is one of the most important pathways for T cells, B cells, and macrophages everywhere. For B cells, it's very important to for the B cell proliferation. You might think that if there is NF kappa beta pathway, there will be immunoglobulin deficiency. So there is where is the risk of autoimmunity? But NF kappa beta pathway is very important for the central tolerance of the T cells as well as B cells and peripheral tolerance of B cells. So you might have a autoreactive clone in the patients with NF kappa beta pathway. Again, the phenotype will have recurrent infections, but they can also have chronic enteropathy, autoimmune cytopenias, hepatosplenomegaly, CLD, and lung-associated ILD like syndromes. Very important to diagnose this, because if you take the same pathway like CTLA4 haploinsufficiency, if you give something like abatacept here, patient will actually worsen. They will not improve for that. So NF kappa beta pathways, again, probably you have to treat the infections, use a grossly immunosuppressive, like more generalized immunosuppressive drugs, and take that patient for probably a transplant if it is feasible. So we have discussed about different infections. So in OPD, if you have a patient with immunoglobulin deficiency, what kind of infections are you expecting? Is the patient with PCP, are you going to think about a possible immunoglobulin deficiency? Is the patient is having aspergillus, are you probably thinking about a possible immunoglobulin deficiency? This is what we are going to discuss in an ID physician's perspective. So the important principles of any infections is, especially the viral infections, you have to ask two important questions. First is whether it is an RNA virus or a DNA virus. DNA virus is a big virus most of the times. They will have enough genome. They can have multiple immune evasive mechanisms. So the amount of immunodeficiency required for T cell, the DNA viral reactivation is quite high. And many of the times this virus can actually stay within the cell without coming out. So antibodies are not effective in general for a DNA viruses. If you have a case of zoster and that's responded when you give IVIG, that is not the response to IVIG. So immunoglobulins are grossly not very effective for DNA viruses. Whereas RNA viruses, they do not have that much of genome. They depend upon the host genome for the replication. They try to mutate to evade the immunity. So that is the reason why most of the viral infections, RNA viral infections, short-lived. You'll not have a latent influenza, whereas you'll have a latent herpes virus. Okay, so they are short-lived infection, but they try to mutate, and it's very important for them to come out of the cell to spread to other cell. And when they are coming out, the antibodies can actually neutralize them. So neutralizing antibodies are very important for RNA viruses, especially RNA viruses which are not enveloped. Enveloped RNA viruses can again transfer from one cell to another cell, but non-enveloped RNA viruses are the viruses which are likely to infect a patient with immunoglobulin deficiencies, right? So among the respiratory viruses, most of the respiratory viruses enveloped. Non-enveloped respiratory virus is rhinovirus. Now you actually go and search in PubMed what will happen, what are the what is the phenotype of rhinoviral infection in patients receiving rituximab. They keep on shedding rhinoviruses without able to clear. Sometimes rhinovirus, which is supposed to cause just upper respiratory tract infection, will be causing pneumonia in patients with antibody deficiency. Capsulated bacterial infections, which we have already discussed about. So these are the reports. If you go through this paper, then you see that the prolonged rhinoviral shedding in patients with immunoglobulin deficiency. Again, we have discussed about how capsulated bacterial infections are very prone in a patient with immunoglobulin deficiency. We tend to forget about pertussis, but pertussis is again a capsulated bacteria which can cause very bad syndromes in patients with immunoglobulin deficiency. So this is the patient. You can see because of the recurrent infections, you can see there is a lot of bronchiectasis. So this could be one of the presentation. Young male patient coming to the OPD with recurrent infections and bronchiectasis. Probably you have to suspect a possibility of immunoglobulin deficiency. Some patients with bronchiectasis now will have a cystic bronchiectasis where actually something like aspergillus can sit. So they can present with aspergilloma. They can also present with something like ABPA. You can see a high attenuated mucus here. Bronchiectasis is the pre-requirement, one of the pre-requirement for ABPA. So young patient coming with ABPA, with bronchiectasis, again, you have to ask this question: why this patient has bronchiectasis? Is it just post-infective, or is there any possibility of a common variable immunodeficiency? You can also see this CT, which is labeled as a upper left corner. You can see a lot of lymphatic nodules. If you don't give me any history, and if you say that this is the CT, I will say it is probably sarcoid or lymphangitis carcinomatosis. But this is the patient with CVAD, with the chronic, we call it as GLLLD, granulomatous lymphocytic interstitial lung disease, right? Similarly, these patients can develop follicular bronchiolitis, can have organizing pneumonia-like pattern, can also have something called LIP, which can cause cystic lung disease. So most common presentation of CVID lung, if it is not because of infection, could be because of granulomatous lymphocytic interstitial lung disease, organizing pneumonia-like pattern, or follicular bronchiolitis. Again, this is the patient who presented with recurrent episodes and chronic, let us say it is a chronic encephalitis, encephalitis in a patient with immunoglobulin deficiency. So you are expecting a RNA virus which is not capsulated to cause chronic encephalitis. The organism is enterovirus. If you see a MRI like this involving pons and dentate nucleus of cerebellum in a patient with immunoglobulin deficiency, you are looking at a chronic enteroviral encephalomyelitis. This is very important. There are a lot of reports of patients developing chronic encephalitis because of after giving rituximab. The another radiological pattern you can see is a periventricular demyelination, which where patient can be labeled actually as a possible JC virus. If you're not doing a biopsy, JC virus can be negative in patients, especially in patients who are following up with rheumatology. Especially it will be labeled as iris followed by rituximab in a patient who is receiving rituximab, can be labeled as a PMLE. So it is important to know that this is the virus which can cause, so that you can specifically test for enterovirus in these patients. Again, parvovirus is actually a DNA virus, but it is a single strand DNA virus. So actually it behaves like an RNA virus. So if you have a patient with autoimmune cytopenias, you are diagnosed this case as CVID, you are giving immunoglobulins and you are giving some immunosuppression, but despite of that, the cytopenias, especially the hemoglobin doesn't seem to improve. This patient could be a possible parvoviral infection, because again, the immunoglobulin deficiency can actually lead to parvoviral infection. There are other pathways, other combined immunodeficiency, which also increase the risk of parvo, but always in the setting of immunoglobulin deficiency and refractory anemia, you also think about a possibility of parvoviral infection. Again, chronic enteropathy, which we are talking about in CVID, could be because of a virus like norovirus. Again, norovirus is not something which is very specific to B cell immunodeficiency. Usually, we keep seeing noroviral infections in patients with combined immunodeficiency in solid organ transplant patients also. But it is important because there is one paper where they said that the chronic enteropathy associated with CVAD can respond to the treatment of norovirus. But subsequently, many other studies proven that it is not right. But again, one thing to remember is norovirus can actually stay in non-epithelial reservoirs of the intestine, which can lead to recurrent and chronic infection in patients with immunoglobulin deficiency. Many other times, norovirus also comes with something called Giardia, and Giardia will have a ventral surface antigen which keeps on mutating. So it is very important for the antibodies to neutralize Giardia. So patients with CVAD can also present with recurrent Giardia infection. So CVD enteropathy is when we label when the patient is not because of the you kind of patient is having chronic diarrhea, you kind of ruled out all the infections, but then you are thinking about possibly it is a immunodysregulation which is causing CVID, then you label it as CVD enteropathy. If you are seeing any manifestations like malnutrition and weight loss, then probably you call it as a severe CVD enteropathy. It's very important to label it as severe enteropathy, because you keep on giving them some antibiotics or antiparasitic drugs, trying to fit them into one of the infections, but the patient won't respond, lose weight, become malnourished, and eventually succumb to the illness. So the approach to CVD enteropathy will depend upon the cause, and probably if you are able to identify mutations like CTLA4 or LRBA4 or P3 kinase or STAT3 gain of function mutation, there are very specific treatments available for the treatment of this CVD enteropathy. If you biopsy, it can look like celiac disease, but the diet which is recommended for celiac disease, gluten-free diet, is not recommended in CVD enteropathy. It can look like an IBD phenotype like Crohn's and ulcerative colitis. It can also look like a microscopic colitis like lymphocytic colitis. What about liver? Again, patients with CVID with recurrent gut infections, there is immunodysregulation in the gut, which is directly going into the liver. So many of these patients can also have autoimmune hepatitis, sclerosing cholangitis. What is more important is to recognize patients with nodular regenerative hyperplasia. This is very, very important, because once you label the patient as CLD, it will be very difficult to do a hematopoietic stem cell transplant for these patients. So most of the myeloablative regimens or we use, they will have chemotherapeutic agents which are high risk of veno-occlusive disease. So it is important to know the difference between nodular regenerative hyperplasia and CLD. In chronic liver disease, because of the dual supply, we frequently see the caudate lobe is quite hypertrophied. But in nodular regenerative hyperplasia, you will not see that caudate lobe hypertrophy. So if you're seeing a patient with liver which is a little bit enlarged rather than shrunken, and you see a lot of portal hypertension, but there is no abnormal caudate lobe hypertrophy in a patient with CID, think about nodular regenerative hyperplasia, because the treatment is quite different. It doesn't respond to immunosuppressants. You just have to give up supportive care by treating the portal hypertension, nothing more. So all the B cell immunodeficiency disorders, we kind of tried to summarize throughout the presentation, that the management is IVIG, which you can give intravenous or subcutaneous. You treat the infections, probably you have to involve an ID physician. Targeted therapy is available for some of the CVAD disorders like CTLA4 haploinsufficiency, LRBA deficiency. You can give a CTLA4 agonist like abatacept. Leniolisib is approved for PIK3 delta gain of function mutations. For STAT3 gain of function mutations, you can give JAK inhibitors. Very, very important to have supportive care. Patient with bronchiectasis won't respond to just IVIG. You have to give a good chest physiotherapy for sure. Monitor for autoimmunity and lymphoproliferation, especially if you have a patient with autoimmune cytopenias and CVID. These are the patients, again, kind of have an overlap with CVID enteropathy or CVID lung disease. So you have to keep on screening these patients for a possibility of lung disease, so that you can pick it up little early. Probably you can treat it better. And what about hematopoietic stem cell transfer? This is one thing. Whenever we discuss about a primary immunodeficiency disorders, we grossly say that you can do a transplant. But many of the times, patients with immunoglobulin deficiency, they land up in adult OPDs. So in pediatric population, it is very clear. Primary immunodeficiency disorders, especially something like severe combined immunodeficiency or Visco-Tolerance syndrome, the transplantation is definitely associated with a mortality benefit. But what about adults and adolescents? By the time these patients become adult, there can be some end organ damage. There can be a CLD because of autoimmune hepatitis. Patient might have underwent a splenectomy because of refractory cytopenias, even though we are not doing it routinely now. Patient might have a severe malnourishment. Patient will have a end stage lung disease where you cannot do transplant. So it is very difficult to really choose which patient we should transplant, which patient we should just conservatively manage, and which patient we have a very specific treatment. If you have a very specific treatment, shall we continue with that specific agents to block that particular pathway, or should we consider these patients for transplantation after optimizing the autoimmune lymphoproliferation? Now, transplant is very difficult. Once you do a allogenic stem cell transplant, uh, B cells are the last to recover. So most of the times, first 1 month you'll have an engraftment, monocytes will recover. In next 1 to 3 months, you will see the recovery of CD8 T cells and NK cells, and then CD4 T cells, and CD4 T cells and B cells will come. But again, B cells are dependent on CD4 T cells for the antigenic, the class switch recombination. So the it's very important first to have a T cell development, because it depends upon, again, the thymus. So the more elder you are, it's very likely that the thymus is a little bit atrophied, so T cells will not come, and then you can have a T cell dependent B cell deficiency also. So after transplant, patient can actually get stuck somewhere, can behave like something like skid or something like CVAD. Now you are actually transplanting this patient for CVAD, taking all the risk of myeloablation, and at the end, if he ends up in not producing enough antibodies, then it is waste. So most important questions we have to ask before doing transplant is, whom should we transplant and when should we transplant? When we say we should not transplant, and we are transplanting, how to transplant? Should we use a myeloablative regimen? Should we use a reduced intensity conditioning? What is the chimerism which you want to target? You want 100% chimerism, or 50% chimerism is enough? So these are the questions which are not well answered. I will show you some of the data, two studies at least, where you can actually see this is one of the cohort with adults and adolescents undergoing transplant. Most of the times you'll see the data of pediatric age group, where the outcomes of transplant are actually good. But in this particular study, you can see patients with isolated antibody associated immune defects, they have done worst. And especially those who already have a end organ damage prior to transplant, they have done worse. They had more GVHD, and they had a higher mortality. Again, there is one more study from the French PID group. You can again see there is a very high mortality of transplant patients within the first year, because we still don't know how to, like, which conditioning regimen to use, how to manage in the early transplant in these patients. Even though the quality of life appears to be improving over a period of time, you can also see that in the first 5 years, there is a transplant related mortality which is more than patients who are not underwent transplant. Even though there are some baseline differences, this is a retrospective study. It's very important to consider all these factors before doing the transplant. Thank you. If there are any questions, I'll be happy to take them.
Okay. Thank you so much. Thanks, Praveen. That was an amazing session. I myself learned a lot. I'm sure uh, it was very informative for people who have joined. I mean, I will open the session for any questions which may be there.
So I can see
Um,
one comment: microglia are macrophage like cells in the brain, all oligodendrocytes. I think it is a mistake from my side. It is right. It is microglial cells. Oligodendrocytes are more with myelin production. So microglial cells are very specialized macrophage like cells in the marrow. Yeah.
Yeah, but Praveen, they are also immunologically active.
Yeah. So even astrocytes, even though we think that it is just microglial cells, even astrocytes are immunologically active, and also oligodendrocytes are immunologically active in different ways. Yeah. Right.
They also can function as APCs.
Yeah.
They're not just for myelin production. Yeah, but
Yeah.
that amazing session, Praveen. I really liked. I kept going out in and out, so I don't know if there are any more chart sessions. So because of the network, but I really like the way you took it from the most commonly used drugs. Obviously, these they create a kind of deficiency, immune defects that is analogous to what we see primarily in primary immunodeficiencies, whether it's B cell or T cell defects, and that's how best to learn them. You should know why IL-17 inhibition leads to so much fungal infection, why rituximab infection, result in so much of bacterial infection, and why we are not so worried about rituximab in cases of tuberculosis. Why BAFF/APRIL pathway inhibitors now, they although we don't have too many of them right now in India, but they are going to come, and what to expect from them. I think this is the crux. These primary immune defects also, they have variable penetrance, they have variable presentation. So even for an adult, we should keep our minds open, particularly when you have patients who are present with both the features, who have higher infection risk, also prone, significant risk of infection. I don't mind checking them for these immune defects with both autoimmune features and infections occurring together. We have picked up a couple of patients, one with LRBA deficiency and a couple of CVID patients. Definitely, we have picked up in, looking at like this. So, very nice session. Any questions we have? Yeah, other than you asked one question. I think that was interesting. BTK inhibition and lymphoma, was it? And now that chart has gone off. So I think it is pleural effusion because pneumonia is more common. And anything else?
So it is based on the PKPD of ibrutinib. There is another molecule called venetoclax, which is a BCL2 inhibitor. Both will cause fungal infections. Ibrutinib doesn't have penetration into the pleural area, testis, and eye, but it has penetration into the brain. So ibrutinib, we frequently see patients coming with CNS aspergillosis in cases of ibrutinib. Especially these patients will be on posaconazole prophylaxis, which again doesn't penetrate CNS well. Pleural effusion is what ChatGPT suggested me, but if you change it to isolated pleural effusion, it won't suggest you pleural effusion anymore, because ibrutinib doesn't have good penetration. So if you are seeing a patient on ibrutinib not with any pneumonia and just seeing pleural effusion, think about a possibility of relapse. Again, it is a soft pointer. We always see nocardia or aspergillus just sitting in the pleura as well, but it is a soft pointer. It is just food for thought. It is not something which is yes or no type of question. Yeah.
No, very well taken. I think that shows how complex these things are, and we need to keep learning. There's no other way of. I think whenever you're in doubt, you always go back and check the literature and see what is happening. Great.
Right. Apart from that, I think having high index of suspicion always helps. It's always good to, kind of review why the patient is not improving and then think of them. I think as ID physician, when I learned when I started studying ID, we understood the mechanism of these infections very well. But somewhere we also need to understand why they are happening also. So having a very high index of suspicion is always useful, even for. I mean, I think it should be it is required across the facilities, but for ID physicians, because we come across these patients little more than others, I think that's the whole purpose of having this entire workshop.
Thank you.
If there are no other questions, I congratulate you, Praveen. It was amazing. I think I'm sure people really enjoyed it. Anybody who wants to ask any question can unmute themselves and ask it.
Any further
Or
addition?
if no, then we can actually.
Yeah, great. I think
Okay.
I'm very,
I
very
think it
clear. No
was
doubts.
really clear.
So I think we
Clear.
can.
Yes, no doubts. Yeah, we
Yeah.
can wind it up. Yeah.
Absolutely.
Okay. Then we'll actually say.
Yeah, it is. It is an ID physician's perspective also. Amazing.
Yeah.
Thank you, Praveen. Thanks a lot.
Thank you. Thank you.
Bye.
Bye bye. Bye.